Welcome to the 2019 spring updates. One of the things we're going over is advanced airway. We're with Kyle Close, one of our more experienced paramedics, and he's going to tell us about some of the tips and tricks that he uses to obtain success for a first pass intubation.
Okay, so the first thing I look for when I come into the patient is I do a size up and get a general impression as I come through the door or come on scene. What I'm looking for at the patient is the first thing I look for is if they're a no-necker. If they have no neck, and those patients are really hard to intubate. The other thing is if they have a really thick, fatty layer in their neck. As I approach them, those are the first two things I look for. I then grab their jaw. When I grab a hold of their jaw, I'm feeling how pliable and how far I'm able to open that mouth. As I do that, I'm looking for two things. I'm checking out to see how large their tongue is, and when I open their jaw, how much of a gap or a window I'm going to have if I go direct. The next thing I'm looking for is any blood or secretions that I'm going to have to suction prior to intubation.
Kyle, so we talked about your assessment for the airway and how you're going to intubate, what tools you're going to use. What do you do to set yourself up for success? How do you know that you're going to pass this, get this tube on the first pass success?
Okay, so at this point, it's been delegated to me, or I've taken it upon myself that I'm in charge of airway. And at that point, I'm going to be the one getting the ALS airway, which means I need to set myself up for success. The way that I do that is I make sure all the packages that need to get opened are already open and pre-assembled prior to ever picking up the laryngoscope blade. I have already identified with this patient that he doesn't have the fat neck and all of my landmarks, so I know I'm going to be able to successfully intubate him with going direct rather than going with king vision. Any of those other factors, I'm going to go straight to king vision. With this, I have my endotracheal tube. I have it already opened, sitting next to the patient. I also have my 10cc syringe that's already opened up. I've already plumbed my bubble and made sure that it inflated and then deflated it, and I know it's ready to go sitting next to him. I've also taken my Thomas tube holder and I've put it around the neck already. And so once I intubate, I can just bring it straight up and hook it up. Because once I intubate, I own that tube until it's secured. The other thing is I make sure that my BVM is already hooked up to capnography and that's plugged into the monitor. That's just another step and it takes more time. I also don't intubate unless I have my McGill forceps. Because if I go in there and I find that I have something that I need to remove, anything that's a foreign body, I need to have something to be able to do that with so that I don't have to pull out, because at that point we're pulling out and going back to bagging and we can bag it into their trachea. Have this ready. The other thing is you need to always have suction ready, have it already running. It's a little bit loud, but we already have the metronome. Have your suction already running. When I come in to intubate, I hook up, I have suction in my hand. I don't have my tube in the hand. Most of the time, it's going to need to be suction. So I'm going to go in, pull up. I already know if I'm going to need to have any correct pressure. I'm going to suction clear so I have a nice good window to the cords. I'm then going to set my suction down. I'm going to grab my tube out of the package, and I'm going to come up and I'm going to intubate. Through and out. Hold it with my hand. Pull that out. Inflate. I'm going to have whoever's bagging. If I'm bagging, then I will bring it up, hook it right on. If I'm having somebody else, say go ahead and bag. The other part is having this ready. I'm going to secure my tube, and then I set myself up for success by already having my ears. Personally, I like to get my own lung sounds. I own this tube. I watched it go through the cords, and I want to be the one that confirms what my lung sounds and negative epigastric sounds.